Well, thank you for the opportunity to have me discuss the results of our paper that was recently published in Obstetrics and Gynecology and investigated demographic and clinical characteristics, contributing factors and areas for prevention following U.S. maternal deaths from underlying infections from 2017 2019. These were based on data that were reported to the Centers for Disease Control and Prevention from state maternal mortality review committees. And just to contextualize the paper, we know that maternal mortality remains an urgent public health priority and that the United States maternal mortality rate continues to exceed that of all industrialized nations, with most recent estimates ranging from about 18 deaths per 100,000 live births. I wanted to provide a little bit of context about maternal mortality review committees, as these are committees that are established by state or local jurisdictions, and they're really given wide berth to a variety of sources that include medical records, natality data, autopsy reports, social services, legal records, etc. And in that way, they're able to not only accurately identify root causes for maternal deaths, but also create very specific and actionable recommendations that inform local and national prevention strategies. So in this analysis, myself and my colleagues from the Centers for Disease Control evaluated all the intensive work that MMRCs do, and specifically their findings and recommendations for deaths that were coded secondary to an underlying infection. And we found that amongst deaths reported during the 2017 to 2019 time period, 9.2% of maternal deaths were due to an underlying infection. And some of the bigger findings were that these infections most frequently involve the genital tract, and very importantly, that the majority, in fact, 84.6% of these deaths were preventable. And then the MRCs provided and highlighted specific recommendations across levels to reduce and prevent future maternal deaths from infections. We found that when a source was identified, in approximately 48% of the cases, the source of infection was genital. And that when a pathogen was identified, approximately 34% of the time, it was group A streptococcus. We also looked at sort of timeliness in intervention and measured that by timing to antibiotic receipt, which was variably coded. But in the majority of instances, there was a delay in antibiotic administration. And so these together suggest that we have some prevention opportunities that can be done to improve the quality of care patients are receiving, specifically and importantly around genital tract infection. So that can translate to kind of improving clinician examination of the genitourinary tract and maybe enhancing just the underlying sense or diagnostic probability by asking all patients timing of pregnancy, they're currently pregnant or recently pregnant. Um, this also suggests that there's a role for improving group A strep recognition, which we know that invasive group A strep has a very high case fatality, but is extremely treatable with appropriate antibiotic selection and source control. Um, and finally, ultimately, at a facility and health system level, that there are some opportunities that can lead to improved clinician detection and recognitions that can improve provider education, decisional support, and ultimately treatment that can reduce serious maternal infections.